Welcome back to Studious. Today, we begin a new series in community medicine, one of the most important and most underestimated subjects in the entire MBS curriculum. Community medicine is far more than a collection of statistics and definitions to be memorized for examinations. It is the intellectual framework through which the medical system understands health and disease, not just at the level of the individual patient, but at the level of entire populations, families, and communities. Where clinical medicine asks, what disease does this patient have and how do we treat it? Community medicine asks, what is making people sick in the first place? How widespread is that problem across our population? And what systems do we need to build to prevent it, reduce it, and eliminate it? This is medicine operating at its most powerful scale, not treating one person at a time in a consulting room, but designing the systems, programs, and policies that protect millions simultaneously. In this foundational session, we will build the complete conceptual blueprint of community medicine, from the core definitions of illness, disease, and morbidity, through social medicine, the anatomy of a community, the architecture of health programs, and the integrated systems of care delivery.
Before we can study the prevention and management of health problems, we must precisely define what we mean by the terms used to describe them. Three distinct but interrelated concepts form the pathology matrix of community medicine. The first is illness, the subjective state. Illness is a personal, experiential phenomenon. It is the deviation from normal health as perceived and reported by the individual. It is defined by the physical symptoms, pain, fatigue, breathlessness, and the psychological disturbances, anxiety, depression, reduced capacity for daily function that the person consciously experiences. Illness is what the patient reports when they come to you. The second concept is disease, the objective process. Disease is the biological reality underlying the patient's symptoms, a defined, reproducible process of impaired health occurring at the cellular, tissue, or organ level. Critically, disease is often entirely hidden from the patient until symptoms physically appear. A person with early-stage hypertension, early hepatocellular carcinoma, or asymptomatic HIV infection may feel perfectly well. Illness is absent, yet disease is actively progressing. This dissociation between illness and disease is one of the most clinically important concepts in preventive medicine, because it means that waiting for patients to feel sick before intervening is fundamentally inadequate. The third concept is morbidity, the statistical reality. Morbidity refers to the quantitative presence of a disease within a defined population, the measurable burden of illness, expressed as incidence rates, prevalence rates, and disability-adjusted metrics. Morbidity data for conditions such as tuberculosis, diabetes, or paralysis are the primary data inputs for public health planning.
Human health cannot be understood in isolation from the environment in which humans live. This is the foundational insight of social medicine, a discipline that studies the patient not as a biological entity in a clinical vacuum, but as a person embedded within a complex, multi-layered environment that profoundly shapes their health outcomes. The ecological model of man places the individual at the center of three concentric environmental layers. The innermost is the biological environment, encompassing the plants, animals, insects, bacteria, viruses, and other organisms that the person interacts with, and that can serve as sources of infection, nutrition, or ecological balance. The middle ring is the physical environment, the climate, geography, infrastructure, housing quality, sanitation systems, air and water quality, and built environment that determine the physical conditions of daily life. Research consistently demonstrates that the physical environment accounts for a larger share of population health variation than clinical healthcare delivery. The outermost ring is the socioeconomic environment, the economic systems, social structures, employment patterns, educational access, income distribution, and community support networks that govern a person's material circumstances and social capital. Social medicine thus shifts the medical lens from purely curative treatment toward proactive health promotion and disease prevention, addressing the root determinants of health. Alongside social medicine sits the specialized discipline of social hygiene, the applied science of healthful living, with a particular focus on preventing and treating sexually transmitted infections through contact tracing, social network mapping, and patient rehabilitation.
Community medicine, by definition, operates at the level of the community. So, what exactly is a community? In the public health context, a community is defined as a large group of people living together within a defined geographical area, sharing common interests, goals, and ways of life. The community is not merely a collection of individuals, it is a social unit with shared infrastructure, shared health risks, shared cultural practices, and shared vulnerabilities. A rural village, an urban neighborhood, a school, a factory workforce, or a refugee camp may each constitute a distinct community for the purposes of public health intervention. The essential concept is that communities share exposures to contaminated water, to airborne pathogens, to occupational hazards, to nutritional deficiencies, and that addressing these shared exposures systematically produces population-level health gains that individual clinical care cannot replicate. The process of understanding a community's health needs begins with community diagnosis, the active, systematic process of identifying, quantifying, and prioritizing a community's specific health problems. Just as a clinician must diagnose a patient before treating them, a public health team must diagnose a community before designing interventions. Community diagnosis asks three fundamental questions. Who is at risk? What are the precise morbidity and mortality rates for specific conditions? And who requires immediate systemic intervention? The tools of community diagnosis include household surveys, disease surveillance systems, vital statistics analysis, and focused epidemiological investigations.
Two closely related but conceptually distinct disciplines form the theoretical spine of community medicine: preventive medicine and public health. Preventive medicine is defined as the science and art of preventing disease, prolonging life, and promoting physical and mental health and efficiency. The definition contains two components: the science component, which is knowing the evidence, the facts, principles, mechanisms, and epidemiological data that establish what works in disease prevention, and the art component, which is applying that knowledge effectively in the real world, communicating risk to patients, designing behavioral interventions, navigating the social and cultural barriers to uptake of preventive services. The primary actor in preventive medicine is the physician and the medical system, working with individual patients and families. Public health extends the same goals but adds a transformative element: organized community effort. Public health encompasses all the principles and tools of preventive medicine, but deploys them through collective social action rather than individual clinical encounters. The primary actors in public health are the organized public working alongside the medical system, governments implementing sanitation programs, communities building clean water infrastructure, schools delivering health education, municipalities mandating food safety regulations. The classic example of a public health success story is the dramatic reduction in cholera mortality in 19th century London, achieved not by treating individual cholera patients more effectively, but by building sewer systems that removed the contaminated water supply that was causing the epidemic in the first place.
The delivery of community medicine at the population level requires not a single physician working in isolation, but a coordinated, multidisciplinary health team, a unified group of professionals sharing common objectives, each applying their distinct skills and knowledge to address the specific, diagnosed needs of the community. The composition of the health team reflects the breadth of factors that influence community health. The physician provides clinical medical expertise and diagnostic authority. The nurse delivers frontline patient care, health education, and disease surveillance. The community health worker serves as the critical bridge between the formal health system and the community, operating in the social and geographic spaces where clinical facilities cannot reach. The social worker addresses the social determinants of health: poverty, family breakdown, housing insecurity, substance abuse. The epidemiologist designs and executes the surveillance systems, analyzes disease patterns, and generates the evidence base for public health decisions. The administrator coordinates resource allocation, logistics, and programmatic management. The public health expert provides the strategic and policy framework within which all team activities operate. Supporting this human infrastructure is health technology, broadly defined as the application of scientific knowledge to provide care across a complete spectrum of interventions. At one end of the technology spectrum is the simple, low-cost, but profoundly impactful oral rehydration solution, a mixture of glucose, sodium chloride, potassium, and clean water that, since its global introduction in the 1970s, has saved an estimated 50 million lives by reversing dehydration from diarrheal disease. At the other end are MRI scanners, CT imaging systems, and ECG instrumentation.
Health services in community medicine are organized across two fundamental delivery modalities that together constitute the complete architecture of population healthcare. Personal health services are interventions applied directly and individually to specific persons, the traditional clinical encounter, but extended into community settings and preventive domains. Key personal health service categories include maternal and child health services, which encompass antenatal care, supervised delivery, neonatal care, child growth monitoring, and the expanded program on immunization that protects children against the major vaccine-preventable diseases. School health services deliver health education, nutritional screening, vision and hearing assessment, and mental health support to the pediatric population within school settings. Occupational health services protect workers from the specific health hazards associated with their work environments: chemical exposures, repetitive strain injuries, noise-induced hearing loss, and shift work sleep disorders. Each of these personal services has a named recipient: a mother, a child, a school child, a worker, and an individualized intervention delivered directly to that person. Impersonal health services, by contrast, improve individual health indirectly by modifying the environment that surrounds the entire population. These are the structural interventions that no individual can access on their own, but that benefit everyone simultaneously. Safe water supply systems that eliminate waterborne pathogens from drinking water. Systematic drainage and sewage disposal that removes fecal-oral transmission routes. Vector control programs that reduce mosquito and rodent populations to interrupt the transmission of malaria, dengue, and leptospirosis.
The operational machinery of community health is organized into programs, defined in community medicine as ongoing activities operating over an indefinite period until specific objectives are definitively achieved. Programs are not time-limited projects with fixed endpoints. They are sustained institutional commitments that continue until their target condition is eliminated or reduced to a defined acceptable level. Programs are structured in two fundamentally different architectural models. Vertical programs are single disease or single focus initiatives, each with its own dedicated staff, management structure, funding stream, supply chain, and reporting system, organized as independent organizational silos. The classical examples are the national programs for the expanded program on immunization, HIV/AIDS, leprosy, malaria, and tuberculosis. Each of these operates with dedicated field workers, specialized training curricula, disease-specific drugs and diagnostics, and a separate supervisory hierarchy. Vertical programs have the advantage of focus, accountability, and the ability to apply specialized technical expertise to a single problem with intensity and urgency. Their disadvantage is duplication, inefficiency, and the fragmentation of care. A patient with TB and HIV may be required to visit two entirely separate clinics, managed by two separate programs with no communication between them. Horizontal programs, by contrast, merge multiple diverse health interventions into a single integrated delivery mechanism built upon the platform of primary health care. Rural water supply, sanitation, primary education, family planning, immunization, and basic curative services are all delivered through the same community health workers, the same health centers, and the same management structure.
The concept of integrated health services represents the operational ideal of community medicine, the vision of bringing all categories of healthcare, both preventive and curative, together at a single point of contact for the patient and the community. The Integrated Services Hub model organizes health delivery around 4 functional modules operating simultaneously within the same facility and the same visit. Module 1 is Family Planning, a preventive service providing contraceptive counseling, methods, and reproductive health education to individuals and couples, reducing unintended pregnancies, maternal mortality, and the population pressures that strain health and educational resources. Module 2 is the Expanded Program on Immunization, the preventive delivery of vaccines against polio, measles, diphtheria, tetanus, pertussis, hepatitis B, and other targeted diseases to infants and children. Module 3 is the Outpatient Department, the curative arm, delivering clinical assessment, diagnosis, and treatment for sick patients presenting with acute and chronic conditions. Module 4 is the Operation Theater for curative surgical interventions, including obstetric emergencies, trauma management, and elective procedures. The transformative power of integration is captured in a single practical example. A mother who arrives at the health center for a family planning consultation can simultaneously have her infant weighed, receive the next scheduled immunization, and collect oral rehydration sachets for diarrhea management, all in a single operational visit, maximizing the efficiency and impact of both the community's and the health system's limited time and resources.
Comprehensive healthcare is the terminal goal of community medicine, defined as healthcare that addresses all dimensions of health to ensure holistic community survival and prosperity. The concept of comprehensive care is often misunderstood as simply meaning a lot of healthcare or expensive healthcare. In fact, it means care that is complete in scope, that addresses not just disease treatment, but the full 4-quadrant framework of health protection. The first quadrant is prevention of disease, the core preventative medicine mission of stopping conditions from occurring in the first place through vaccination, health education, nutritional supplementation, environmental modification, and behavior change communication. The second quadrant is cure of illness, the clinical medical mission of accurately diagnosing and effectively treating diseases that have already occurred, minimizing their duration, severity, and complications. The third quadrant is prevention of disability, the rehabilitative medicine mission of preventing conditions from progressing to permanent functional impairment through physiotherapy, assistive devices, community-based rehabilitation, and disability-inclusive programming. The fourth quadrant, and the one most frequently neglected in health system design, is prevention of economic insecurity and dependency. Health is not just a biological state, it is a social and economic one. When a breadwinner becomes chronically ill, when a farmer loses her eyesight, when a child's education is disrupted by preventable disability, the consequences cascade through the family and the community. Comprehensive care addresses all 4 quadrants simultaneously, utilizing both personal and impersonal services.
Effective community medicine requires not just the right interventions, but a precise framework for measuring whether those interventions are working. 3 hierarchical metrics of success are used in program planning and evaluation: the goal, the target, and the objective. The goal is the highest level of the hierarchy, the ultimate desired operational state that the entire program is designed to achieve. Goals are broad, inspirational, and long-term. For example, the goal of a national tuberculosis program might be stated as to reduce the burden of tuberculosis to a level at which it is no longer a major public health problem in this country. Goals provide direction and motivation, but are not directly measurable in themselves. The target is the next level down, a discrete, specific, measurable degree of achievement toward the goal. For the same tuberculosis program, a target might be to detect 90% of all new TB cases and successfully treat 90% of detected cases by the year 2030, the internationally adopted End TB strategy targets of the World Health Organization. Targets translate the aspiration of the goal into a concrete, time-bound, numerically defined benchmark. The objective is the most operationally immediate level, the planned endpoint of specific immediate activities that contribute step by step toward reaching the target. Using a cricket analogy to make this concrete, the goal is winning the match. The target is scoring exactly 201 runs to surpass the opposition's total. The objective is executing the specific batting plan needed to accumulate those runs over the course of the innings. Without this 3-level metrics hierarchy, programs cannot be evaluated, Accountability cannot be established, and resources cannot be efficiently allocated.
This final slide brings together every concept we have covered today into a single, unified operational model, the engine of community medicine. The engine runs in 5 sequential steps. Step 1 is the trigger. Community diagnosis identifies the specific morbidity, mortality, and structural health needs of the defined population through epidemiological surveillance, household surveys, and vital statistics analysis. Step 2 is the actor. This diagnosis mobilizes the health team, the interdisciplinary group of physicians, nurses, community health workers, social workers, epidemiologists, administrators, and public health experts who will design and deliver the response. Step 3 is the tools. The health team deploys health technology, from ORS packets to CT scanners, through the organized platform of integrated health services that brings preventive and curative care together at a single point of access. Step 4 is the delivery. The team delivers comprehensive healthcare through both personal health services, targeted at individuals and families, and impersonal health services that modify the environment for the benefit of the entire community. Step 5 is the output. The ultimate goal is achieved. The health of the entire community is measurably improved across all 4 quadrants of the comprehensive care shield. Community medicine is therefore formally defined as the system of delivery of comprehensive healthcare to the people by a health team in order to improve the health of the community. Please like this video, share it with a classmate, leave your questions in the comments, and subscribe to Studious for every new episode in this series.